Two individuals came in for genetic testing based on recommendations from their primary care physicians. The first one is 24-year-old Kurt, who was previously diagnosed with Zollinger-Ellison syndrome and also has an adenoma in one of his parathyroid glands. On the clinical examination, doctors observed that he has gynecomastia. His mother also has parathyroid adenomas. The other one is 19-year-old Courtney, who was previously diagnosed with parathyroid hyperplasia and pheochromocytoma. Her father has recently been diagnosed with thyroid medullary cancer.
Although their presentation and family history differ, both people have multiple endocrine neoplasias, or MEN for short. These are a group of inherited diseases which cause tumors to grow in the endocrine glands of the body. The endocrine glands affected in multiple endocrine neoplasia are the pituitary gland, thyroid gland, parathyroid glands, adrenal glands, and the pancreas. So in multiple endocrine neoplasias, there are tumors that form in these glands that lead to overproduction of hormones. Multiple endocrine neoplasias are caused by genetic mutations in one of two genes, either MEN1 or RET, which codes for receptor tyrosine kinase.
For your exams, remember that both of these genes have a dominant inheritance pattern, so only one copy of the mutated gene is needed to get the disease. Okay, let's start with MEN1 gene that is found on chromosome 11 and codes for a tumor suppressor protein called menin, which, under normal circumstances, stops a cell from dividing uncontrollably. MEN1 mutations cause MEN type 1. For your tests, you absolutely have to know that there are three types of tumors associated with MEN type 1: parathyroid, pancreatic, and pituitary. The most common tumor is a parathyroid adenoma. Increased parathyroid hormone production causes increased bone breakdown, which leads to hypercalcemia. The clinical manifestations of hypercalcemia can be recalled by the mnemonic stones, bones, groans, and moans. Stones refers to the calcium kidney stones. Bones refers to the bone pain that results from the increased resorption of bone and hyperparathyroidism. Groans refers to the abdominal complications in hypercalcemia, including peptic ulcer disease, pancreatitis, and constipation. Lastly, moans refers to the psychiatric symptoms of hypercalcemia, such as altered mental status and psychosis. Pancreatic tumors cause problems based on the type of hormone they produce. The first one is Zollinger-Ellison syndrome, where there's only one or more tiny tumors in the pancreas or the upper part of the small intestine. These tumors, called gastrinomas, produce gastrin, which increases the amount of hydrochloric acid in the stomach and can cause peptic ulcers, abdominal pain, and vomiting. Insulinomas cause hypoglycemia, which is suggested by the Whipple's triad. This includes symptoms of hypoglycemia such as hunger or dizziness, low glucose levels at the time of the symptoms, and finally, relief of symptoms when glucose is given. On the other hand, glucagenomas cause hyperglycemia, but glucagenomas are pretty rare.
Sometimes the tumor is a vipoma, which secretes vasointestinal active peptide and leads to watery diarrhea, which can lead to dehydration, metabolic acidosis, and hypokalemia.
The pituitary gland develops benign tumors called adenomas, which usually make an excessive amount of at least one of the many hormones produced there. Most commonly, there's excessive prolactin, which causes galactorrhea, or milk production in women who are not breastfeeding, and gynecomastia in men, which is excessive breast tissue growth. The next most common hormone being overproduced is growth hormone, which has different effects depending on the age. In children, growth hormone causes gigantism, meaning they'll get really tall. In adults, growth hormone causes acromegaly, where they have enlarged hands and feet, a large forehead, and a prominent jaw. Sometimes, with MEN type 1, there can also be facial angiofibromas, which are benign tumors that consist of blood vessels and connective tissue. They appear as small, reddish papules that don't regress. Next, there can also be collagenomas, which are caused by the proliferation of normal collagen fibers. They are also benign and appear like multiple skin-colored or hypopigmented nodules on the face, neck, trunk, and upper limbs. Finally, meningiomas can also appear. These are benign tumors that arise from the meninges, which are the membranes that surround the brain and spinal cord. In most cases, meningiomas are asymptomatic. Okay, moving on to MEN type 2. It's caused by a mutation in the RET gene, which is a proto-oncogene that promotes normal cell division. When it mutates, it becomes an oncogene, which promotes constant cell division.
Mutated RET causes multiple endocrine neoplasia type 2A and 2B.
In MEN type 2A, the most common problem is thyroid medullary cancer, which develops in virtually everyone with the disease. This type of cancer develops from parafollicular cells, or C cells, in the thyroid that produce calcitonin and can metastasize to other organs through the blood. In this case, since thyroid medullary cancer is so frequent, a prophylactic thyroidectomy is needed. Next, the adrenal medulla form tumors called pheochromocytoma, which make too much epinephrine and norepinephrine. This results in episodes of high blood pressure, headaches, palpitations, anxiety, and sweating. In addition, pheochromocytomas may secrete erythropoietin, resulting in polycythemia.
People with multiple endocrine neoplasia type 2A can also develop parathyroid hyperplasia, where all four parathyroids are enlarged and produce too much parathyroid hormone.
Similar to parathyroid adenomas, this results in hypercalcemia and its symptoms. In MEN type 2B, the type of tumors are the same as 2A, except there is no parathyroid adenoma. This is something you absolutely have to know for your exams. Instead of parathyroid adenoma, 2B have multiple mucosal neuromas, which are tumors that come from nerve tissue. With MEN type 2B, these affect the nerve fibers in the ganglia, which is called ganglia neuromatosis. Ganglia neuromatosis usually occurs in the mouth, but can also happen in the intestine. Also, another high-yield fact is that people with MEN type 2B tend to have a marfanoid habitus. This means that their physical appearance is similar to those individuals with Marfan syndrome. This includes long limbs, sometimes with an arm span that exceeds the height of the individual, as well as long fingers and a high arched palate.
Alright, as a quick recap, MEN type 1 is caused by mutations in MEN1 gene, and you have to remember the 3 Ps: parathyroid adenomas, pancreatic tumors like insulinomas, lipomas, and glucoconomas, as well as gastrinomas that cause Zollinger-Ellison syndrome, and finally, pituitary tumors, which often release prolactin or growth hormones.
In some cases, there can also be angiofibromas, collagenomas, and meningiomas. Then there's MEN type 2, which is caused by mutations in the RET gene. With MEN type 2A, there are only 2 Ps: pheochromocytoma and parathyroid hyperplasia. Apart from this, individuals with MEN type 2A usually have medullary thyroid cancer. Finally, there's MEN type 2B, which is also caused by mutations in the RET gene. With MEN type 2B, there's also 1 P, pheochromocytoma. Apart from this, as with MEN type 2A, there's also medullary thyroid cancer. However, MEN type 2B is uniquely associated with mucosal neuromas that affect the mouth and intestine. Now back to our cases. The first one is 24-year-old Kurt, previously diagnosed with Zollinger-Ellison syndrome, most likely due to a pancreatic gastronoma, and parathyroid adenoma with a family history of parathyroid adenomas. Another clue is the gynecomastia, so we should get a prolactin level and a head MRI to check for a pituitary adenoma. Unsurprisingly, the results of his genetic testing show a mutation in the MEN1 gene, so he has MEN type 1. The other one is 19-year-old Courtney, previously diagnosed with parathyroid hyperplasia and pheochromocytoma, with a family history of medullary thyroid cancer. The results of genetic testing showed a mutation in the RET gene, so she is diagnosed with MEN type 2A. Courtney was advised to get a prophylactic thyroidectomy to prevent medullary thyroid cancer.
The multiple endocrine neoplasias, or MEN for short, are a group of inherited diseases which cause tumours to grow in the endocrine glands of the body. The endocrine glands that can get affected in multiple endocrine neoplasia are the pituitary gland, the thyroid gland, the parathyroid glands, the adrenal glands, and the pancreas. So, in multiple endocrine neoplasias, there are tumours that form in these glands, and that leads to overproduction of the hormones that they produce. So a logical way to do this will be to go through the glands that are affected and talk about what they do. The pituitary gland is a pea-sized gland found at the base of the brain, and that makes the hormones that control many of the other endocrine glands in the body. These hormones include thyroid-stimulating hormone, which acts on the thyroid to make thyroid hormone, adrenal corticotropic hormone that acts on the adrenal glands to make cortisol, follicle-stimulating hormone and luteinizing hormone, which acts on the ovaries and testes to make estrogen in women and testosterone in men. So it's the boss, right? It's like the king of the endocrine gland, telling them how much hormone to produce. Now, as if that wasn't enough, the pituitary also makes growth hormone, which makes you grow, funnily enough. It also makes prolactin, which stimulates milk production in women, oxytocin, which triggers milk release, antidiuretic hormone, which helps the kidneys to reabsorb water, and melanocyte-stimulating hormone, which helps the melanocytes to create more melanin, or pigment. Next on our list, we have the thyroid gland, which makes thyroid hormones, and they control metabolic rate. It also makes calcitonin, which is a hormone that decreases calcium levels. Within the thyroid gland are buried 4 parathyroid glands, and these make parathyroid hormone, which, quite on the contrary to calcitonin, actually increases calcium levels. So, moving down the body on our whistle-stop tour of the multiple endocrine neoplasias, we've got the adrenal glands, which sit just above each kidney and produce epinephrine and norepinephrine. These are the hormones that we're referring to when we talk about the fight or flight response, and they're involved in increasing cardiac output, dilating the pupils, and increasing blood flow to the muscles. You know, the kind of stuff you'd need if you were going to fight. Or fly, I suppose. Finally, on our journey down the glands, we have the pancreas, which makes insulin to help lower blood sugar, and glucagon to help raise the blood sugar. The pancreas doesn't stop there, though. It also makes gastrin, which increases hydrochloric acid production in the stomach, and vasoactive intestinal peptide, which relaxes the intestinal wall and allows food to pass. But how do they come about? Well, multiple endocrine neoplasias are caused by genetic mutations to one of 2 genes, either MEN1 or RET. Both of these genes have a dominant inheritance pattern, so you only need 1 copy of the mutated gene to get the disease, unfortunately. The MEN1 gene is found on chromosome 11 and is a tumour suppressor gene, which means that normally it's able to stop itself from dividing uncontrollably. A MEN1 mutation causes multiple endocrine neoplasia type 1. On the other hand, RET is what's called a proto-oncogene, which promotes normal cell division, and when it mutates, it becomes an oncogene, which promotes constant cell division. Mutated RET causes multiple endocrine neoplasias type 2A and 2B. In multiple endocrine neoplasia type 1, there are 3 types of tumours. Those are parathyroid, pancreatic, and pituitary. The most common type of tumour is a parathyroid tumour. An increase in parathyroid hormone causes increased bone breakdown, which leads to hypercalcemia and calcium kidney stones. Pancreatic tumours can cause problems based on the type of hormones they produce. A gastrinoma produces gastrin, which increases the amount of hydrochloric acid in the stomach, and this can cause peptic ulcers, abdominal pain, and vomiting. Insulinomas produce an excess of insulin, and since insulin lowers blood sugar, you can end up with hypoglycemia. While a glucagonoma causes hyperglycemia because it promotes the breakdown of glycogen to release glucose. The pituitary gland develops non-cancerous tumours called adenomas, and these usually make an excess amount of at least one of the many hormones that are produced there. The most common is a prolactinoma, where there's excess prolactin, which causes galactorrhea, or milk production in women who aren't breastfeeding, and gynecomastia in men, which is breast tissue growth. Next, there can be excess growth hormone, which causes something called gigantism in children, which is where they grow really tall, or acromegaly in adults, where they have enlarged hands and feet, a large forehead, and a prominent jaw. A handy little way to remember the 2 most common hormones released by pituitary adenomas is the phrase, lots of milk leads to giant kids, where lots of milk refers to prolactin, and giant kids refers to growth hormone. In multiple endocrine neoplasia type 2A, the most common problem is thyroid medullary cancer, which develops in virtually everyone with the disease. This type of cancer forms from the C cells in the thyroid that produce calcitonin, and it can metastasize to other organs through the blood. The adrenal glands form tumours called pheochromocytomas, which make too much epinephrine and norepinephrine. This results in high blood pressure, anxiety, and sweating. People with multiple endocrine neoplasia type 2A can also develop parathyroid adenoma, but unlike in type 1, only about half of the people will develop this type of tumour. Moving on to multiple endocrine neoplasia type 2B, the type of tumours are the same as 2A, thyroid medullary cancer and pheochromocytoma, but there is no parathyroid adenoma. Instead, they have multiple neuromas, which are tumours that come from the nerve tissue in the skin and the mouth. So, as you can probably imagine, the symptoms of multiple endocrine neoplasia depends on the type of tumour and the hormone that's produced, as well as from the mass effect and the local inflammation from the tumour itself. In men type 1, a pituitary adenoma might press on nearby brain tissue, causing headaches, or it could press on the optic nerves, causing vision problems, such as bitemporal hemianopia. In men type 2A and men type 2B, thyroid tumours might compress nearby organs in the neck, causing hoarseness, coughing, and trouble swallowing. In men type 2B, neuromas typically grow on the tongue, lips, and roof of the mouth. Multiple endocrine neoplasia can be diagnosed by genetic testing to find out the underlying genetic mutation. When it comes to treatment, the genetic defect can't be treated, but the tumours can be cured with surgery if caught early. If type 2 is diagnosed, then a thyroidectomy will inevitably be performed, and this is to prevent thyroid medullary cancer. The thyroid may also be removed in the family members of those who carry the defective gene, and this is to prevent thyroid cancer in the future. Okay, so that was a real whistle-stop tour of multiple endocrine neoplasias. So let's go over some of the key points. Multiple endocrine neoplasias are divided into 3 types: type 1, type 2A, and type 2B. Men type 1 causes parathyroid, pituitary, and pancreatic tumours. Type 2A and type 2B cause medullary thyroid cancer and pheochromocytoma. Type A also causes parathyroid tumours, and type B has multiple neuromas instead of parathyroid tumours.
Carcinoid syndrome refers to a constellation of symptoms like diarrhea, shortness of breath, and flushing, which arise when a specific type of tumor called a neuroendocrine tumor begins secreting hormones. Neuroendocrine tumors were also called carcinoid tumors in the past because of their association with carcinoid syndrome. Neuroendocrine cells are found in tissues throughout the body, particularly in the epithelial layer of gastrointestinal organs and the lungs. They receive signals from nerve cells, and in response, they release hormones into the blood. Neuroendocrine cells release a variety of hormones, including amines like serotonin and histamine, polypeptides like bradykinin, a vasodilator, and prostaglandins, which are also powerful vasodilators. The production of these hormones can also be regulated by other hormones. For example, somatostatin is a hormone that's made by cells in the hypothalamus as well as the gastrointestinal tract, and it travels through the blood and binds to receptors on the surface of neuroendocrine cells. Binding of somatostatin inhibits the release of a number of hormones from neuroendocrine cells, including serotonin. Now, when serotonin does get released from neuroendocrine cells, it enters the liver through the portal vein. In the liver, some of the serotonin is metabolized to 5-hydroxyandoleacetic acid, which is eliminated from the body through the urine. The remaining serotonin is not metabolized, and this portion remains in the systemic circulation where it has various effects. In the gastrointestinal tract, serotonin increases motility and peristalsis. In the vasculature, platelets take up the serotonin and later use it to constrict blood vessels, particularly after injury. And in the connective tissue of the heart, it stimulates fibroblasts, which make lots of collagen. A cell can become cancerous when DNA mutations cause abnormal cellular functions, like uncontrolled, unregulated cellular divisions forming a tumor. The limitless replication means the developing tumor can invade nearby tissue and spread through the blood and lymph to distant sites in the body called metastasis. If a neuroendocrine cell mutates and transforms into a cancerous cell, then that cell can continue dividing until it becomes a little mass, which is a neuroendocrine tumor. And most of the time, these neuroendocrine tumors develop in the gastrointestinal tract. Some of the abnormal functions of the cancerous neuroendocrine cells include producing and secreting large amounts of hormones, and, counterintuitively, they also express more somatostatin receptors on their surface, particularly in the gastrointestinal tract, although it's unclear why that happens. Neuroendocrine tumors tend to be slow-growing, although some can metastasize, often depending on the location. Common primary sites for neuroendocrine tumors are someplace along the small or large intestines, as well as the stomach, pancreas, and liver, the lungs, the ovaries in females, and the thymus. The most common site for a neuroendocrine tumor to metastasize to is the liver. So the liver can really be a primary or secondary site of the disease. And it turns out that metastasis, especially to the liver, is often necessary for carcinoid syndrome to occur. That's because it leads to liver dysfunction, which decreases the liver's ability to metabolize the hormones which get released from the neuroendocrine cells, allowing them to build up and cause symptoms. Increased histamine and bradykinin can cause vasodilation leading to flushing, while histamine can also cause itching. Increased serotonin can cause thickening of the collagen, called fibrosis, in the heart valves, leading to heart dysfunction. Most often, fibrosis affects the right side of the heart, causing tricuspid regurgitation and pulmonary stenosis, and bronchoconstriction leading to asthma, shortness of breath, and wheezing. Fibrosis can also affect the abdominal mesenteries as well as the retroperitoneal area. In the latter situation, extensive fibrosis may cause ureteral obstruction and impair kidney function. The increased synthesis of serotonin also reduces the amount of tryptophan available to the body to make niacin, vitamin B3. Reduced levels of niacin can cause pellagra, a disease which causes symptoms like inflamed skin and mental confusion. The most common symptoms of carcinoid syndrome include diarrhea, shortness of breath, and flushing and itching. These symptoms can be worsened by alcohol or emotional stress, since these can further stimulate the neuroendocrine cells. To diagnose carcinoid syndrome, a urinalysis can be done, which usually shows increased levels of 5-hydroxyindoleacetic acid, while blood tests can show a niacin deficiency. Identifying the primary neuroendocrine tumor can be done through medical imaging techniques like a CT or MRI scan, or through techniques that identify the number of cells that express somatostatin receptors, like the Octria scan or the gallium-68 PET scan. With an Octria scan, a radio-labeled somatostatin analog, octreotide, is injected, and it binds to the increased number of somatostatin receptors on tumor cells. A gamma camera is then used to pick up the radioactive octreotide signals and translates them into an image that shows where the tumor is. Another diagnostic imaging technique, called a gallium-68 PET scan, uses the same principle, and it seems to be more accurate at detecting neuroendocrine tumors. Treatment of carcinoid syndrome is aimed at stopping hormone production from the neuroendocrine cells. This can be done with somatostatin analogs, which bind to the somatostatin receptor and inhibit hormone release. Decreasing emotional stress and alcohol consumption can also help limit hormone release. Treatment of the primary tumor is usually done through surgical resection. Alright, as a quick recap, carcinoid syndrome is a set of symptoms that occur when a neuroendocrine tumor secretes excess serotonin, histamine, and bradykinin. The classic symptoms include diarrhea, shortness of breath, and flushing and itching. Diagnosis can be made with an octreotide scan, as well as elevated 5-hydroxyindoleacetic acid in the urine and decreased niacin levels in the blood.
Neuroblastoma is a type of tumor composed of neuroblasts, specifically neural crest cells, which are cells involved in the development of the sympathetic nervous system. Neuroblastoma is the most common cancer in infants, and it's only rarely seen in children over 5 years old. When a fetus is in its 5th week of development, special cells called neural crest cells start migrating along the spine. In the thoracic region of the spine, neural crest cells differentiate into the neurons of the sympathetic chain, lying on either side of the entire spinal cord. In the lumbar region, neural crest cells differentiate into the cells of the adrenal medulla, the inner part of the adrenal gland that sits atop the kidneys. Together, the sympathetic chain and adrenal medulla form the sympathetic nervous system, connecting the brain and central nervous system to various organs including the heart and blood vessels. So, when you're under some sort of stress, maybe playing a super competitive sport like badminton, the sympathetic nervous system kicks into action. The sympathetic neurons release norepinephrine, also called noradrenaline, and the cells of the adrenal medulla release norepinephrine and epinephrine, also called adrenaline. These hormones bind to receptors in various tissues like the blood vessels, the heart, and the lungs, redirecting blood flow to your muscles, making your heart pump faster, and expanding the airways in your lungs, all of which can help you make that winning hit. After the game is over and the hormones are no longer needed, epinephrine and norepinephrine break down into metabolites like homovanillic acid, or HMA, and vanillylmandylic acid, or VMA. In neuroblastoma, some neural crest cells in the sympathetic chain or the adrenal medulla don't differentiate properly during fetal development, and these cells ultimately go on to form a tumor, which most often forms in the adrenal medulla but can also develop in other areas of the sympathetic chain. While no one knows exactly how it happens, this abnormal cell differentiation has been associated with mutations in the MYCN oncogene, anaplastic lymphoma kinase ALK fusion oncogenes, and mutations in tumor suppressor genes, like the paired-like homeobox 2b, or FOX2b, and other tumor suppressor genes on chromosome 1 and 11. Oncogenes help cells grow and proliferate, while tumor suppressor genes slow down cell growth and proliferation. So, both an MYCN amplification, or ALK gene fusion, where the oncogene is turned on, or a FOX2b in chromosome 1 and 11 deletions, where tumor suppressor genes are turned off, can potentially cause uncontrolled cell growth. There are 3 types of neuroblastomas, and they're categorized based on the size and shape of the tumor cells: undifferentiated, poorly differentiated, and differentiating neuroblastoma. An undifferentiated neuroblastoma is mostly comprised of neural crest cells, which are sometimes called small round blue cells, due to a lack of cytoplasm and a large blue nuclei. A poorly differentiated neuroblastoma is composed of slightly more differentiated cells, with smaller nuclei and a bit more cytoplasm. In addition, the cells of a poorly differentiated neuroblastoma may be surrounded by a substance called neuropil, which is a dense network of interwoven nerve fibers like axon and dendrite branches. Finally, a differentiating neuroblastoma is composed of cells with lots of cytoplasm and is often surrounded by a substance called Schwannian stroma. Schwannian stroma is a connective tissue from non-neuronal cells that forms myelin, which insulates the axons of the mature neurons. When any type of neuroblastoma forms, cells in the surrounding tissue release chemokines called CXCL12, and that stimulates nearby immune cells. CXCL12 is normally produced by some organs like the lymph nodes, liver, bones, and especially the bone marrow, but gets produced in higher amounts when the tissue is damaged. When immune cells sense high levels of CXCL12, they get stimulated and move towards the area where it's coming from. As it turns out, neuroblastic tumor cells also get stimulated by CXCL12. If a neuroblastoma cell breaks away and gets into the blood or lymph, it will sometimes migrate towards the organ where CXCL12 is normally produced, creating metastatic tumors there. Symptoms of neuroblastoma result from the chemokine release and include fever, weight loss, sweating, and fatigue. Other symptoms of neuroblastoma depend on where the tumor is located and are usually a result of the tumor pressing up against surrounding organs. For example, if the tumor is in the thoracic region of the sympathetic chain, it can grow into the lungs, causing breathing difficulties. A thoracic tumor that extends to the neck can press up against nerves originating there, and heading toward the face, it can cause Horner syndrome. Horner syndrome involves meiosis, or constriction of the pupils, ptosis, or the drooping of the eyelid, and anhidrosis, which is an inability to sweat in the face. Tumors on the sympathetic chain might also grow into the spine, causing neurologic symptoms, like muscle weakness or bowel and bladder problems. Children with a tumor in the adrenal medulla can have a large, painful abdominal mass that causes abdominal swelling. About half of all blastomas spread to the bones, causing bone pain and small fractures. Classically, neuroblastomas can cause fractures at the base of the skull, just where the skull connects to the spine. With these fractures, fluid and blood can leak into the tissues around the eyes. When that happens, it can cause periorbital ecchymosis, also called raccoon eyes, because of the dark rings of blood that can be seen in the soft tissue around the eyes. Neuroblastoma that invades the bone marrow can also affect the marrow's ability to make healthy red blood cells, platelets, and white blood cells, leading to fatigue, easy bruising, and frequent infections. Diagnosis of neuroblastoma usually starts with testing for HMA and VMA in the blood or urine, since high levels of those metabolites may indicate tumors that secrete epinephrine and norepinephrine. A CT scan can show location and size of the tumor, and a complete blood count can help determine whether neuroblastoma has spread to the bone marrow. Treatment largely depends on the size and staging of the neuroblastoma, meaning how far the tumor is spread. Early on, surgery can be used to remove the tumor, but once it's started to spread, it might require a combination of chemotherapy, medication, and even stem cell or bone marrow transplantation. Generally speaking, the best treatment outcomes are among the youngest patients that have a differentiating neuroblastoma. Alright, as a quick recap. Neuroblastoma is a condition where neural crest cells of the developing sympathetic nervous system and adrenal medulla do not differentiate normally. Rather, they continue to proliferate in an immature state, creating tumors that press on nearby organs or spread to other organs causing complications, like Horner syndrome and raccoon eyes. High levels of HMA and VMA are usually the first indication of a neuroblastoma. Opsoclonus myoclonus syndrome is also called OMS, or dancing eyes, dancing feet syndrome. Opsoclonus describes seemingly random, involuntary, and rapid eye movements in the horizontal, vertical, and diagonal directions. Myoclonus describes lightning-like limb movements or limb jerks that can also be more tremulous. The syndrome also causes ataxia, which often results in the inability to walk, sit, or crawl, and the loss of previously attained abilities, like speech. Generally speaking, OMS is thought to be an autoimmune condition in which the body attacks the nervous system, resulting in the characteristic signs and symptoms. The precise cause of OMS is unknown, but in children it's often due to a paraneoplastic syndrome. The idea is that a hidden or occult tumor, like a neuroblastoma or ganglioneuroblastoma, triggers the body's immune system, and the resulting antibodies unintentionally target healthy cells of the nervous system. CD20 positive B cells that get into the cerebrospinal fluid seem to play an important role. One brain area that gets affected is the cerebellum, which plays an important role in coordinating body movements. In older children and adolescents, OMS is thought to be triggered by an infection, and in adults, it's often due to a paraneoplastic process due to a lung or breast cancer, for example. In children with OMS, there's almost always ataxia, so it's sometimes referred to as OMAS, with the A representing ataxia. In fact, most toddlers with OMS are initially misdiagnosed with acute cerebellar ataxia of childhood. The diagnosis of OMS is also often based on symptoms like opsoclonus and myoclonus, which can appear abruptly, progressing over days to weeks. Other symptoms include the loss of developmental milestones like speech, developing extreme irritability, and severe sleep disturbances. Although there is no diagnostic test, a spinal tap can be done to look for evidence of antibodies, called oligoclonal bands, in the cerebrospinal fluid. And lymphocyte flow cytometry can be done to look for an increased amount of CD20 positive B cells in the CSF. Finally, a CT scan, MRI scan, PET scan, or a combination of these can be done to help identify tumors that may have triggered OMS. Finally, it's important to ensure that the symptoms are not due to other processes, like brain tumors or other lesions, which can also be identified on the imaging studies. Immunosuppressive treatment options for OMS include corticosteroids, adrenocorticotropic hormone, intravenous immunoglobulin or IVIG, cyclophosphamide, and rituximab, which is a manufactured antibody that targets CD20 positive B cells. If a tumor is found, it's usually removed by surgery and rarely requires chemotherapy. To help treat insomnia and rage attacks, certain medications can be used. In mild cases, symptoms often improve or resolve completely, whereas in severe cases, there may be residual symptoms for life, and relapses can be common. Alright, as a quick recap, opsoclonus myoclonus syndrome is a rare condition with prominent ataxia and behavioral changes, known for the unique eye movement opsoclonus, which is conjugate, involuntary, and rapid movements of the eyes in every direction, and quick, shock-like movements in the arms and legs, called myoclonus. The cause is thought to be either paraneoplastic or parainfectious in most cases. The diagnosis typically involves imaging, while treatment includes immunosuppressive therapy in addition to treatment for any tumor that's identified.
With pancreatic neuroendocrine neoplasms, neuroendocrine refers to pancreatic cells which release hormones in response to signals from nerves, and neoplasm refers to a cancer. So, pancreatic neuroendocrine neoplasm is a cancer of the neuroendocrine cells that are within the pancreas. They can also be called pancreatic neuroendocrine tumors, or just PAN-NETs for short. In addition to endocrine cells, the pancreas also has exocrine cells, which make up a majority of the gland. Most pancreatic cancers arise from exocrine cells, and they're called adenocarcinomas, whereas only a minority arise from pan-NETs. Now, the pancreas is a long, skinny gland about the length of a dollar bill, which sits to the left of the duodenum and behind the stomach, in the upper abdomen, or the epigastric region. It plays two main roles. There's the exocrine part of the pancreas, which has acinar cells that make digestive enzymes that are secreted into the duodenum to help digest food. There's also the endocrine part of the pancreas, which has a few different types of islet cells, or neuroendocrine cells, each of which make different hormones. These neuroendocrine cells are present in clusters, or islands, called islets of Langerhans. The largest group of cells are the beta cells, which secrete insulin. Insulin mainly lowers the blood glucose levels by transporting glucose into the cells. It also pushes potassium into the cells, which decreases potassium in the blood. Another group are the alpha cells, which secrete glucagon. It raises the blood glucose levels by getting the liver to generate glucose from amino acids and lipids, and to break down glycogen into glucose. There are also delta cells, which secrete somatostatin, which decreases the release of other hormones, including insulin, glucagon, and serotonin. There are also gamma cells, also called pancreatic polypeptide cells, which secrete pancreatic polypeptide, and stimulates the release of digestive enzymes from the stomach and small intestine, as well as slow down intestinal movement. Finally, there are a few rare types of cells called enterochromaffin cells, as well as D1 cells and G cells, which are scattered in the islets of Langerhans. Enterochromaffin cells secrete serotonin, which helps with motility of the gastrointestinal tract. D1 cells release a hormone, vasoactive intestinal polypeptide, or VIP, which relaxes the small intestine and stimulates the release of intestinal digestive enzymes, but inhibits hydrochloric acid release from the stomach. G cells are found in the pancreas and stomach, and they secrete gastrin. Gastrin stimulates the parietal cells of the stomach mucosa to secrete hydrochloric acid, and also stimulates the glands in the epithelial layer. In pancreatic neuroendocrine neoplasms, one of the many types of neuroendocrine cells mutates and starts dividing uncontrollably, forming a tumor over time. Sometimes the mutation is in a tumor suppressor gene, like PTEN and MEN1. Tumor suppressor genes usually regulate cell growth, so when they mutate, the result is uncontrolled cell growth. Mutation of the MEN1 gene results in an inherited condition known as multiple endocrine neoplasia, or MEN type 1, where adenomas or malignant tumors form in the parathyroid gland, pituitary gland, and pancreas. Some pan-NETs are benign tumors, which means that they don't invade nearby tissues, whereas others are malignant tumors, meaning that they do invade surrounding tissues and even metastasize or spread through the lymph to distant ones. Pan-NETs are classified into functional tumors, which secrete hormones, and non-functional tumors, which don't secrete any hormones. Non-functional pan-NETs are more common, and they're usually asymptomatic until they grow to a large size and metastasize to other organs like the liver. Large tumors can compress surrounding structures. For example, a tumor might compress the common bile duct, leading to a backup of bile and causing obstructive jaundice, which is when the skin turns yellow from the buildup of bilirubin in the tissues. Functional pancreatic neuroendocrine tumors are less common and depend on the type of cell they arise from and the hormone they produce. The most common functional pancreatic neuroendocrine tumor is an insulinoma, which arises from beta cells that make insulin. Insulinomas are usually benign solitary tumors that cause hypoglycemia, or low blood glucose, and in severe cases can lead to confusion and loss of consciousness. The second most common type is a gastrinoma that arises from the G cells that make gastrin. Gastrinomas secrete large amounts of gastrin, which produces a syndrome called Zollinger-Ellison syndrome. Excess hydrochloric acid erodes the mucosa, which results in peptic ulcers. A unique feature of Zollinger-Ellison syndrome is that the peptic ulcers are formed not only in the stomach and the duodenum, but there's so much acid that ulcers are formed in more distant parts of the small intestine, like the jejunum. The acid also inactivates the pancreatic digestive enzymes, which allows food, especially fat, to pass right through the intestines undigested, leading to greasy and smelly stools, called steatorrhea. The third most common type of pancreatic neuroendocrine tumors is a vasoactive intestinal polypeptide, which arises from the D1 cells that make vasoactive intestinal peptide. Vasoactive intestinal polypeptidomas, or VIPomas, result in WDHA syndrome, where WD stands for watery diarrhea, which is due to increased fluid secretion by the small and large intestine. H stands for hypokalemia, or low potassium levels in the blood due to potassium losses in the intestinal fluid. And A stands for achlorhydria, the absence of hydrochloric acid secretion. The fourth type is glucagonoma, which arises from the alpha cells that make glucagon. Excess glucagon leads to increased blood glucose, resulting in diabetes mellitus. Glucagonomas also result in a loss of lipids and proteins that are used to form glucose, and they typically cause a necrolytic migratory erythema, which is a red blistering rash that mostly affects the mouth and limbs. The fifth type is somatostatinoma, which arises from the delta cells which secrete somatostatin. The excess somatostatin inhibits release of other pancreatic hormones, like insulin, gastrin, and VIP, which leads to diabetes mellitus, steatorrhea, and hypochlorhydria, or decreased hydrochloric acid secretion. Finally, there are also pancreatic neuroendocrine tumors that develop from pancreatic polypeptide cells and enterochromaffin cells, but these ones are very rare. Diagnosis of functional pancreatic neuroendocrine tumors is based on measuring pancreatic hormone levels. Non-functional tumors are usually hard to detect, since no increased hormone levels can be found in the blood. In addition, MRI or CT imaging of the pancreas can help identify a tumor and estimate its size. The treatment for a pancreatic neuroendocrine tumor depends on the type and size. When dealing with a functional tumor, with the exception of somatostatinomas, somatostatin-like medications are given to reduce hormone production. In addition, gastrinomas can be treated with medications that block gastric acid secretion. When dealing with non-functional pancreatic neuroendocrine tumors, large tumors that cause compression can be managed with surgery. Alright, as a quick recap, pancreatic neuroendocrine neoplasms, or PAN-NETs, are tumors of hormone-producing cells of the pancreas, and their symptoms depend on their size and cellular origin. PAN-NETs can be non-functional tumors, meaning they don't produce any hormones, or they can be functional tumors, meaning they do produce hormones. The most common types of functional tumors include insulinomas that make insulin, gastrinomas that make gastrin, glucagonomas which make glucagon, VIPomas that make vasoactive intestinal peptide, and somatostatinomas that make somatostatin.
Hey guys, thanks so much for watching. Hope you're able to find this video useful, especially in differentiating between the various types of pancreatic tumors. This video is brought to you by Janavi, who wrote the script, Rishi, who edited the script, Tanner, who did the voiceover, Evan, who did the video editing, and I did the video illustrating. If you're looking for a deeper dive into this topic or into the topics of any of our other videos, definitely check us out at osmosis.org. We not only have hundreds of more videos on there that haven't been released to YouTube, but we also have awesome stuff like flashcards, quizzes, and a bunch of other tools that really help you learn and study easier. So definitely check it out. And if you enjoy watching our videos, definitely continue to share us with your friends on social media, and definitely send us comments. We love hearing your opinions and thoughts. It helps us make better videos for you guys. So until next time, see you later, guys.
Zollinger-Ellison syndrome, named after Dr. Zollinger and Dr. Ellison, who were the two surgeons to first describe it, is a rare endocrine disorder where there's actually three interrelated pathologies. First, there's a gastrinoma, which is a gastrin-secreting tumor. Second, the gastrinoma leads to increased gastric acid secretion from parietal cells. And third, all that extra gastric acid causes peptic ulcers. Normally, the inner wall of the entire gastrointestinal tract is lined with mucosa, which consists of 3 cell layers. The innermost layer is the epithelial layer, and it absorbs and secretes mucus and digestive enzymes. The middle layer is the lamina propria, and it has blood and lymph vessels. The outermost layer of the mucosa is the muscularis mucosa, and it's a layer of smooth muscle that contracts and helps with the breakdown of food. Now, in the stomach, there are 4 regions: the cardia, the fundus, the body, and the pyloric antrum. There's also a pyloric sphincter, or valve, at the end of the stomach, which closes while eating, keeping food inside for the stomach to digest. The epithelial layer in different parts of the stomach contains different proportions of gastric glands, which secrete a variety of substances. Having said that, the cardia has mostly foveolar cells that secrete mucus, which is mostly made up of water and glycoproteins. The fundus and the body have mostly parietal cells that secrete hydrochloric acid and chief cells that secrete pepsinogen, which is an enzyme that digests protein. Finally, the antrum has mostly G cells that secrete gastrin in response to food entering the stomach. These G cells are also found in the duodenum and the pancreas, which is an accessory gland of the gastrointestinal tract. Now, gastrin stimulates the parietal cells to secrete hydrochloric acid, and also stimulates the growth of glands in the epithelial layer. In addition, the duodenum has Brunner glands, which secrete mucus rich in bicarbonate ions into the lumen. With all the digestive enzymes and hydrochloric acid floating around, the stomach and duodenal mucosa would get digested if not for the mucus coating the walls and bicarbonate ions secreted by the duodenum, which neutralizes the acid. Since the stomach walls are constantly exposed to the acid, they have a thicker mucus layer when compared to the duodenum, which is only momentarily exposed to the acid. In addition, the blood flowing to the stomach and duodenum brings even more bicarbonate, which again helps neutralize the hydrochloric acid. Finally, small signaling molecules called prostaglandins get secreted in the stomach and duodenum, and they stimulate mucus and bicarbonate secretion, as well as vasodilation of the nearby blood vessels, which allows more blood to flow to the area. And this promotes new epithelial cell growth, and also inhibits acid secretion. All these neutralizing mechanisms help in making the lumen of the small intestine basic. This basic environment is needed to activate the pancreatic digestive enzymes, like pancreatic lipase, which breaks down fat. In Zollinger-Ellison syndrome, G cells in the pancreas or duodenum develop a mutation, which makes them divide uncontrollably and develop into gastrinomas. These can be benign tumors, which means that they don't invade nearby tissues, or malignant tumors, meaning that they do invade surrounding tissues and even spread through the lymph to distant ones. In either scenario, the gastrinomas secrete large amounts of gastrin, which results in excess hydrochloric acid secretion. That ends up overwhelming the protective bicarbonate and erodes the mucosa, which results in peptic ulcers. The thin mucus layer of the duodenum is unable to protect it from the hydrochloric acid, so ulcers usually form in the duodenum rather than in the stomach. Deep ulcers cause perforations, which means they erode all the way through the walls of the stomach or duodenum, allowing undigested food and gastric secretions to get into the peritoneal space, which is usually sterile. Very deep ulcers can also erode into blood vessels running along the walls of the stomach or duodenum and cause bleeding. Also, increased hydrochloric acid makes food entering the duodenum really acidic, which inactivates the pancreatic digestive enzymes. Increased gastrin also stimulates so much growth of the glands in the epithelial layer that there's thickening of the mucosal layer. Gastrinomas can arise sporadically, or they can be part of an inherited syndrome. Sporadic gastrinomas are more common and usually happen as solitary tumors. On the other hand, inherited syndromes that cause gastrinomas, like multiple endocrine neoplasia, or MEN, type 1, are less common and usually cause multiple tumors. Multiple endocrine neoplasia type 1 is an autosomal dominant disorder, where a mutation in a tumor suppressor gene leads to adenomas or malignant tumors in the parathyroid gland, as well as the pituitary gland and the pancreas. Most of the symptoms of Zollinger-Ellison syndrome are due to the peptic ulcers. This includes epigastric pain, which is an aching or burning in the upper abdomen, as well as bloating, belching, and vomiting. Gastric ulcer pain typically increases while eating, because the food can irritate the ulcer and there's more hydrochloric acid produced while eating. In contrast, duodenal ulcer pain typically decreases while eating, because the closed pyloric sphincter doesn't allow hydrochloric acid into the duodenum. Another symptom is diarrhea due to incomplete digestion and absorption of food, and in some cases steatorrhea, which is when there's undigested fat in the feces. The diagnosis of Zollinger-Ellison syndrome usually starts with the detection of peptic ulcers during endoscopy, and is confirmed by detecting high levels of gastrin in the blood, especially if they're still elevated after giving secretin, which normally inhibits gastrin release. An abdominal ultrasound can also be done to help detect the tumors. Treatment for Zollinger-Ellison syndrome includes medications which lower the gastric acid secretion, and surgery might be needed to remove solitary tumors. Alright, as a quick recap, Zollinger-Ellison syndrome is a rare endocrine disorder characterized by a triad of one or more gastrinomas, increased gastric acid secretion, and peptic ulcers. The main symptom is epigastric pain from peptic ulcers, but also includes steatorrhea, and diarrhea might also develop due to incomplete digestion and absorption. Zollinger-Ellison syndrome can be treated with acid-lowering medication and surgery to remove solitary tumors.